Okay, exam 3, part 1. Okay, so for the first 2 lectures, it's going to be the neuropathies by Shams, and then we'll go to Campbell's lectures. So I kind of just combined them. Okay, so I included some definitions and I included a few slides. I sort of broke apart his slides and then I would highlight the way I like have it organized this time is I would highlight on his slide what I thought was probably important after I took a few slides to break it down. So peripheral neuropathies are dysfunctions, obviously, of the peripheral nervous system. So think of like arms and legs. Neuropathy is a dysfunction of the nerve cell body itself. Polyneuropathy, so think of like many nerves. Mononeuropathy is just one nerve. So an example of that would be at like the head, or the Saturday night palsy. So a patient has their arm across a chair, got drunk, like what we learned about an MGA, and now they've got entrapment of that radial nerve. So that would be a mononeuropathy. Or like somebody had like compression to the head of the fibula. So now that common fib nerve is going to be entrapped. Okay, mononeuritis multiplex. If you hear that, that would be multiple nerves involving different limbs. So usually if you think something more proximal, it's going to affect all the nerves below. But with this, you might have like an arm and a leg involved instead of just like one leg or both legs. Radiculopathy is abnormality at the nerve root. So sometimes patients will have like back pain or sciatica or something like that with radiculopathy. You'll hear physicians say that. And so know that it's at the nerve root, so in the back. Polyradiopathy is going to be multiple nerve root levels, so like L5S1. Polyradioneuropathy is going to be multiple nerve roots and trunks. Okay, so that's some definition so you know what that is if you ever hear it. So some classifications are going to be axonal or demyelinating. And we'll talk about some like Gilliam Beret or MS that are demyelinating, that destroys the myelin sheath. Okay, so we've got the peripheral nervous system, and we talked about peripheral neuropathies. So he gives this definition. I think it's probably not important to know, but he had highlighted that there's this principle that distal weakness is more common than proximal. And when we talk about diabetes, it's got this stocking and glove pattern. And so if you think about wearing gloves and you think about wearing socks, you've got like distal weakness right at your socks and your gloves. So I went ahead and threw in diabetic neuropathy, even though it's like covered later in the lecture. It's the most common cause, and he kind of just brushes past it, but it's good to know because when you're on clinicals, like this is what you're going to see most often when you face neuropathy, not like some of these random ones that you'll probably like never see. I say that, and then like sometimes I see the craziest things. It's like you're told, oh, you'll probably never see this, and it's like there it walks in, But anyways, you'll probably see diabetic neuropathy a whole lot. And it's probably because of like metabolic and vascular abnormalities. And you'll hear it again when you get to endocrine. Okay, so there's inherited and acquired neuropathies. So the inherited one are going to be the Charcot-Marie tooth. And then the acquired ones are going to be everything else. Okay, so the inherited ones, Charcot-Marie-Tooth disease. So Charcot-Marie-Tooth, the fun part of about, and you probably already know, but there, for pretty much everything that you're going to learn, there's going to be like a name or a person's name associated with the disease, and then there's going to be something like that describes it. On board exams, they always use the person's name, and when you're out like in the real world, they always use people's names. They never call it hereditary motor sensory neuropathy. They would always call it Charcot-Marie-Tooth disease. So, but for exams at DCOM, I would probably know both names. Yeah, it's totally to make it harder. And like one of like my preceptors, he asked me what some ligament was of the thyroid. And it's like it's not even an important one. It's like the suspensory ligament of the thyroid that just holds it to the neck. Anyways, he was like super old. And apparently it's called the Beret ligament that we never learned. So, you might get asked something that like nobody even called. I mean, they've not called it that in like a million years. So just fun things. And there's one disease and it's got 3 names, but I don't remember what it is. Anyway, so back to it. Charcot-Marie-Tooth disease, there's type 1 and type 2. Type 1 is worse than type 2. So there's going to be this demyelination, remyelination pattern. And so the nerves become palpably enlarged. So you can it's kind of similar, I don't know, in my mind, to sort of like bone. So you know how we've got osteoclast, osteoblast, and they're constantly like remodeling and our bones. So if we have too many osteoblasts making bone, and then we have osteoclasts like getting rid of them, then sometimes that would make that wouldn't be good. Well, it's the same thing except with the nerves, with the myelin. So if we have constant like rebuilding of it and taking it away and then putting a bunch back together, we're going to have these like this ropey feeling of nerves that aren't going to work as great. So that's what Charcot-Marie-Tooth is. And I sort of think, which is weird, but I sort of think of like somebody like gnawing off corn. So if you're like biting off of it and you just like chew or like really anything, and you just chew a little bit here and a little bit there, and then if you like felt it with your hand, it would feel sort of gnawed off and like bumpy. And so that's how these nerves feel. So that's how I remember it. Okay. So clinical features besides these gnarly nerves are going to be reduced sensation. It's going to be neuropathy. And then they've got this pes cavus deformity of the feet. So if I was writing a test question, I would have a picture of this crazy looking foot, which is on the next slide. And then contractures of wrist, fingers. So it's going to be similar to what the foot is going to look like. They'll have scoliosis because of contractures. And then because we have we have lack of sensation, we're also going to have motor function is going to be impaired because we're not getting that signal across. And if it's in the ear, it can be associated with hearing loss. Okay, so we're not to that yet, but we will get there. They can also have, because of distal calf muscle atrophy, they can get that stork leg deformity. And I think that's it. Frequently sprained ankles because of the weakness as well. So it might be caused by a duplication of the PMP22 gene. So since it's a gene, I would probably know it because they probably could throw that in there. They can give you this great, all these like, show you a picture of the foot or the stork leg deformity, tell you about sprained ankles, tell you about this palpable enlargement, and then ask you what the gene is. So you know it's Charcot-Marie tooth, but like you got to also remember that gene. So that makes it a third order hard question. So here's the picture. So you can see it looks just like contracted. And here we've got that stork leg deformity because of the weakness of the calf. Okay, so here's some more signs and symptoms. And so here's the like curled fingers, looks similar to like a foot, how it's contracted. So I saw something similar to this. It wasn't Charcot-Marie tooth, but it was this lady got Botox in her leg because she had a contracture on Monday because she had had a stroke. So they were treating her with Botox and physical therapy and hoping to relax this muscle so that she'd be able to do therapy. So kind of cool. Okay, so Charcot-Marie tooth 2 can be caused by a lot of different subtypes. And he has these in yellow. I just don't know if it's like that important to know, honestly. But he put it in yellow, so maybe it's important to know the genes. But I just feel like he'd probably ask a question about one instead of type 2. And basically it's the same as type 1, just lesser. So other diseases would be like multi-system disorders like Huntington's, with the chorea, involuntary jerking, ataxia, and remember it's autosomal dominant. Okay, acquired, which would be, remember, is everything else. So Guillain-Barré syndrome, also called acute inflammatory demyelinating polyradicular neuropathy, so, or AIDP. We've all heard this, and I guess you guys had Collie for this. I don't know who taught what lecture, but anyways, in one of the micro lectures. Symptoms are going to be by distal paresthesias following ascending muscle weakness. So remember, with Guillain-Barré versus other things, it's going to be an ascending paralysis. It can affect all the way up to the cranial nerves. It can cause respiratory failure. That's what would kill the person. And they can have serious complications. So back from micro days, our bacterial cause would be Campylobacter jejuni. Now in the age of COVID-19, viral infections can cause it as well as it could be caused by, it's like very, very rare, but like from vaccines. Other stressors, pregnancy, surgery, immunizations can cause Guillain-Barré. So how do we diagnose it? We're going to, first off, get a good history and physical. It's always important to ask your patients lots of good questions, as we're taught. And then a lumbar puncture. It's going to have elevated protein, but no cells. And this is differentiated from our like encephalitis and our meningitis that I think we talk about next week. So it'll have protein, but like with a meningitis, we're going to have white cells, but this doesn't have white cells. This just has the elevated protein. Okay, so our treatment is going to be, of course, supportive care. If a patient can't breathe, you got to put them on a vent. Make sure that they eventually get like good physical therapy, occupational speech, make sure their vitals are okay, good pain management. They probably don't feel good. Make sure that if they're like intubated, they need to be able to eat. So you have to put like a OG tube, so oral gastric tube down and get them like nutrition. But the overall treatment is going to be IVIG or plasma. So this is going to differ from our next next disease. So know that there's no role for steroids in this one, only IVIG or plasma. Okay, so here's his thing. So Gilliam Beret, most frequent demyelinating neuropathy, viral GI infections, Campylobacter, jejuni. Remember, it can lead to respiratory paralysis. It's ascending. CSF shows protein, no cell count. And then we're going to give them IVIG. Okay, CIDP. Next one is going to be a chronic disorder. So it's not acute, and it's going to affect people of any age, but usually middle-aged. And it's affecting the proximal and distal muscles, usually beginning in the lower extremities. So a nerve biopsy shows like an onion bulb formation. I just thought I'd throw that in there because I know it's not on his slide, but it's just something to know. Something that like Campbell would like. But anyways. Treatment. This is how it differs from Guillain-Barré. The treatment is going to be corticosteroids, as well as like plasma exchange and IVIG. It's just remember that Guillain-Barré, we don't use steroids, but for CIDP, we can use steroids. And it's very helpful. Okay. So it's going to be acute to begin with, and then it progresses. CSF, very similar. The nerves may become enlarged, and remember, use steroids. Okay. Vasculitic neuropathy is the mononeuritis multiplex or distal symmetric polyneuropathy. So it may be associated with immunoglobulins that are in that precipitate in the cold. So remember in hematology in the first block, you learned about the warm and the cold immunoglobulins that people sometimes have like anemias with. So same thing. This would be like a cryoglobulinemia. These words are hard. They may have a Raynaud phenomenon, may have renal failure, purple lesions on their skin. And other causes are that Church-Strauss, which I know is in heme, Sjogren's syndrome, and then Wegener's granulomatosis. I think this is the one that might have. I know it has multiple names, but anyways. And then prednisone and cyclophosphamide are going to be the treatment for this. Okay. Here is polyarteritis nodosa. And you get all of these, again, like hit harder. And they're really important to know, like when you get to cardio, but you'll get all of the artery ones all over again. So it's kind of like a preview to that. Here's Raynaud. Here's Sjogren's. They've got dry eyes, dry mouth with Sjogren's. With Wegener's, it's going to be a three processes. It involves the sinuses, it involves the upper respiratory sinuses, it's going to involve the lower respiratory like lungs, and then it will also involve the kidneys. And so they can also have these skin lesions. All of them can. Okay, amyloid neuropathy is going to be this aggregate of amyloid proteins that are going to form in nerves when they're produced in excess. So you've got an amyloid problem anyways, and it can cause a neuropathy. So we've got painful small fiber neuropathy. Plus, everything else that amyloid plaque can cause. Okay, so this is a cross section of the sciatic nerve with the amyloid. So we can see the apple green birefringence in B. Okay, hyperthyroid neuropathy. The most important thing that I would know about hypothyroidism is that the tendon reflexes are reduced or absent. So I've seen in questions before that it gives you a bunch of stuff and you're not like really sure if it's hypothyroidism. Usually hypothyroidism is pretty easy to pick out, but sometimes they're pretty vague when they ask questions. And you're not totally sure if it's hypothyroidism, which you'll learn more about when you get to endo. It causes depression, weight gain, increased sleep, and a whole list of things. Well, one of them is going to be tendon reflexes are going to be reduced or absent. So anytime that I saw that, I thought, well, it's probably hypothyroidism because other things like depression don't cause that. So know that with hypo, we've got reduced reflexes. And then with hyperthyroidism, we've got weakness and fasciculations. So remember, fasciculations are going to be seen with lower motor neuron diseases. Okay, celiac neuropathy. So celiac disease, you've probably heard of it because it deals with people who can't ingest and break down gluten as well. So gluten is in wheats and found in barley, rye, bread. Patients with HLA-DQ2 or 8 alleles with like TG-IgA or gliadin antibodies may have celiac disease, and they may have a peripheral neuropathy associated with that. And this is due to the fact that they'll have a lot of diarrhea associated with this. And because of celiac, which you'll learn more about in GI, I feel like I just introduce every class, but anyways, it's how it is in the beginning. There's going to be lack of absorption of B12, which can cause neuropathy. Okay. Neuropathies associated with hepatic diseases are going to be like primary biliary cirrhosis, which you will also learn about in GI. And it can cause xanthomas, and here's a picture of a xanthoma, and can cause neuropathy. Okay, HIV neuropathy. It is acute and distinguishable from AIDP because they have HIV, or is not distinguishable from AIDP. Sorry, I read that wrong. Except the cause is HIV. And then, so medications also used to treat HIV also causes neuropathy. So they have HIV, they get neuropathy because of HIV, and then you treat HIV and they get neuropathy. Kind of bad. Okay, post-herpetic neuralgia is going to be, if we think herpetic, where does that come from? Herpes. So it's herpes zoster, usually. So this is going to be the, so shingles. A patient gets shingles. They've got like usually a pain, like sharp, burning pain in a pattern of a dermatome. So they've got sensory disturbances, and then all of a sudden they break out in a rash. Well, months later, they're still having pain, even though the rash is gone, which is rough. So here's shingles. And it's actually like affecting on this guy V1 and V2 because it's on his nose. Okay, so zoster has that inflammatory necrosis of the dorsal root ganglia. So treatment is going to be steroids, antivirals like acyclovir, valacyclovir, analgesics, Tylenol, ibuprofen, and then maybe amitriptyline or nortriptyline. And sometimes they'll give gabapentin. Topical agents help as well. I know a lot of patients have said lidocaine helps. Capsaicin, I don't know if that would help. I feel like that would burn. Oral medications, tricyclic antidepressants or anticonvulsants, and then neural blockades. So just know that it is this neuropathy that may start before or after the appearance of shingles. Sarcoid, usually associated with African Americans, and they have elevated calcium. They've got that positive ACE. There's going to be granulomas and then bilateral hilar lymphadenopathy. You see sarcoid over and over and over again. They love asking about sarcoid. So you'll see it in pretty much every class. Okay, heavy metals, arsenic, mercury, lead, they can also cause neuropathies. Alcohol. So the neuropathies associated with alcohol is usually due to nutritional deficiencies like thiamine. Also, like alcoholics are known to have folate deficiencies as well. They may have like burning pain in chronic alcohol drinkers, and they may fall a lot. Diabetic neuropathies, we've already talked about. It's got that glove and stocking distribution, and it's best maintained with good glucose control, which is harder than what you think because people love their little Debbie cakes. Okay, so radiation neuropathy, patients being treated for cancer and then get radiation, and then radiation causes fibrosis and microvascular injury and can cause paresthesias. So not good. You treat one thing and you get something else. Lyme disease. Remember the rash, erythema migrans. It looks like the target symbol. And then they can get a painful radiculitis 2 to 3 weeks after the rash. So usually if there's a peripheral neuropathy, there's an underlying pathology. If you're a good doctor, you're going to figure out what that pathology is and treat the pathology instead of just the neuropathy. And then, so make sure you ask lots of good questions and try to like figure out patterns so you know which one that they ask. Okay, so that's all of this. And so now we'll switch to cranial nerves. Okay, so I took this from the first, I think our like last two kind of fell off the page, but anyways, I took this from our last the first exam, my slides. This is all of them, and then I just included his examples. Okay, so I guess it was just on there twice. Okay, so anosmia, so loss of smell. Think of like COVID-19, runny nose, head trauma, masses near the cribriform plate, other degenerative conditions like Alzheimer's and Parkinson's can lead it. And remember Kelman syndrome, which is that X-linked recessive disorder with the impaired GnRH migration to the forebrain. It can cause lack of smell. It's like one of the only diseases that, that's like genetic that affects smell. So Good one to remember. You can think of like can't smell the kale. I don't know. Okay, trigeminal nerve. Cranial nerve 5 is going to be receive general somatic inputs from cranial nerve 5, and it's going to provide that sensation for the face in the anterior 2/3 of the tongue. So with a neuralgia, there's going to be brief severe pain in that usually V2, V3 distribution, usually like a cold burst of wind, chewing can aggravate it. Make sure that you rule out tumors and you don't just assume that's what this is. And then treatment is going to be carbamazepine. That's the most common treatment. Okay, Bell's palsy. It looks like a stroke, but it's not one. It just affects cranial nerve 7. So you've got facial drooping, but you have no other deficits. And it's usually caused by herpes zoster. Treatment is going to be acyclovir and IV steroids. And also like to note, they're just besides the drooping, they may not be able to close their eye. So they may have dry eye because they can't close it all the way. They may have drooling because their mouth is not able to close it all the way. Then they might have hyperacusis because they're going to have subpedius muscle weakness. So like think of the things that go along with that as well. Okay, cranial nerve 8, vestibulocochlear, hearing loss. So ways to test for hearing loss, we've got the Rhine test and the Weber test, and you learn this in EPC, and I hope you guys did well on your practical today. So the Rhine test is going to be conductive hearing loss where like you hit the tuning fork. I think you get this in second semester, but you hit the tuning fork and you put it by their ear, and if you put it to the bone, the mastoid bone, and if the bone conduction is greater than the air conduction, then that is going to be sensorial hearing loss on that side. Weber test is going to be if you place the tuning fork on the midline of their forehead. In conductive hearing loss, the sound is going to be louder on the affected side. So with sensory neural hearing loss, the sound is going to be louder on the opposite side. So, which would make sense, kind of. Okay, so cerebropontine angle tumors, usually, let me see, let me go back. Okay, I know it says like the vertex of the skull, but when we learned it in EPC, we just put it on the forehead, in the middle of the forehead, because it's not touching any hair in the middle of your forehead. So, because like hair can disrupt sound waves. So I know it says that, but it's not what we do. That's not what like it's not what they do in ENT, because they do this test on like every person that comes through the door. Okay, acoustic neuromas is sort of a misnomer because they're called schwannomas. They arise from a division of cranial nerve 8. It's usually affected by the trigeminal nerve, and compression causes can cause ipsilateral ataxia or hemiparesis. So it can also cause hearing loss. And think about it. Remember that 7 and 8 come out of the same place. So it can also affect an acoustic neuroma can cause you to have facial drooping. So if you have facial drooping on one side and you have hearing loss, it's not Bell's palsy. We've got a tumor. So always make sure you get a good history. Okay, dizziness and vertigo also in cranial nerve 8. True vertigo is going to be like the room is spinning, not lightheadedness, can't pass out, and you already tested over dizziness and vertigo. Just remember it's with cranial nerve 8. Here's the Dix-Hallpike maneuver. It's a great maneuver. I would learn how to do it because one day it might help if you do the Epley maneuver and Dix-Hallpike maneuver. It might help you diagnose and then treat a patient with vertigo because vertigo stinks. And usually those patients are pretty miserable. So you can treat them and maybe don't have to give them medicine, or can give them medicine, but they're already fixed out the door. Okay, glossopharyngeal neuralgia, of course, affects the glossopharyngeal nerve. Cranial nerve 9. I used to get glossopharyngeal and hypoglossus confused. So they're in alphabetical order, G before H, so 9 before 12. Just in case you get on the exam and you get nervous and can't remember anything. So it's really similar to trigeminal neuralgia, but they've got sharp lightning bolt sensation of severe throat and ear pain. And it's not strep, it's glossopharyngeal neuralgia. Okay, injury to the recurrent laryngeal nerve. This is also fan favorite for people to test on. In anatomy, neuro, endocrine. It's just in so many subjects. So you can test on it multiple times. So it can occur during surgery of the carotid enteroidectomy, also thyroid surgery, cervical disc surgery. So I included a picture so that you could see it. So that right side is going to loop under the right subclavian. Yeah, the right subclavian. And then the left is going to loop under the arch of the aorta. So you can see how it's pretty close. Here it is to the thyroid, and it's looping right here as we get to the carotid. So it could be cut, and that would be bad because if it's cut, then the patient is going to have either not be able to speak, or they're going to have a hoarse voice for the rest of their life, and then they'll sue. So bad day. It can also occur not from a surgeon cutting it, but from an infiltration of an apical lung tumor, so a Pancoast tumor. Okay, glomus tumors are going to affect 9, 10, and 11. It's really rare. And it can sometimes be seen on an otoscopic exam as a fleshy vascular mass. And so resection, radiation are used. Dysarthria are going to be abnormal articulation of speech. So somebody that had a stroke, if they're speaking slow, they're not making sense, you can, go back and tell the doctor that they had dysarthria. Makes you sound smarter than just saying they had abnormal speech or slow speech. It can affect multiple nerves. It's usually caused by infarcts, MS, brainstem lesions, alcohol, myasthenia gravis, anything that you can think of. Dysphagia is going to be trouble swallowing. And there's like oral or prep phase. It may infect just food, or it may be a person's affected with food and liquids. Could be progressive, it could be not. You'll learn about it in GI. It can be caused by multiple lesions, or just different things going on. Pseudobulbar effect is going to be, I think there used to be a commercial about this, and it was a brainstem nuclei and that are involved in laughing and crying. So I wish I like included the little, it'd be kind of fun, included the little commercial. Was it? Oh, well, yeah, the Joker could be kind of an example. So a patient or a person tells you like a really sad story, and then this person just starts laughing, or they just laugh at inappropriate things, or they get so happy. Well, sometimes people just get really happy and they cry, but like, they're just sitting there, let's say just like sitting in the middle of a lecture, and somebody just burst out bawling. And this happens every day. This could be a pseudobulbar effect. It may be an upper motor neuron. And so like the new DEXA was, that was the commercial that is used to treat it with. So dextromethorphan, so that is like a congestant, or like for congestion. I don't really know if the limbic system, I mean, it would make sense if the limbic system was included. I think that they probably like don't know everything about this. And so they're kind of like guessing. Some of like the neurology things, you'll see it more with psych. But like some of this stuff, it's like, what the brain does, but the brain is still something that's so there's so much that you can learn about it. So it's caused like emotional incontinence. So like incontinence, like somebody peeing on themselves or having a bowel movement on themselves. But this is like having emotionalness on themselves at like bad times. I know. So it's kind of interesting. And I don't really know how the treatment works. It doesn't make sense to me, but cool, kind of cool. Okay, CNS infections by Campbell, by Nana Campbell. Do you guys call her that? Do you call her Nana? That's what we call her. Anyways, so route, site, and mechanism. Okay, yeah. We all called her Nana, so you guys should start calling her Nana too. I think she knew it. I don't really know. We never said it to her face. So, but my class and the class before me, the ones that just graduated, they all called her Nana. And maybe like the third years now. I don't know. Okay, because like she just looks like she would be like your grandma or your Nana. Anyways, I love her. No professionalism points deducted. Like, I think she likes it. Okay. So routes are going to be, think all the way back to MFM1. We go all the way to, back to like when we learned about cancer. I almost feel like it was like fourth block or third block. I don't know. That's like thinking way back. So I'm not really sure. But when learning about cancer, there's like different types of spread. There's hematogenious spread, there's direct implantation, there's local extension, and then there's transport. So homogeneous spread means goes through the blood. Direct implantation, you got hit and something stabbed you, like, a cancer directly implanted. Local extension, you've got a cancer that is in the sinuses, and it travels to the cavernous sinus in the brain and affects the nerves. Transport along nerves are like rabies or herpes zoster. So sites are going to be like the meninges, so the subarachnoid space. Meningitis in the subarachnoid space, meningioencephalitis, encephalomyelitis, or focal infections. So mechanisms are going to be direct cell injury or injury by toxins. So bacterial infections. So the most common kind are going to be strep pneumo. It's going to be the most common type of bacterial meningitis. For neonates, it's going to be a little bit different. It's going to be E. coli and then group B strep. So they test moms twice before they have a baby for group B strep. Even if they think they're going to do a C-section, they still check them for group B strep because they don't want the baby to have meningitis. E. coli. Think about where E. coli comes from. Poop. It's pretty close there when a baby's being born. So that's why those two are the most common. So kind of just think through, okay, what's the most common causes of things? Adolescence. Neisseria meningitis. So remember back to micro. And it can cause Waterhouse friction syndrome, which is hemorrhagic infarction of the adrenal glands. And then in elderly, it can be caused by listeria. But the most common for adults is going to be strep pneumo. And like adolescents can get strep pneumo, as well as elderly, as well as neonates. But anyways, causes of bacterial meningitis can cause, like chronically, can be TB, neurosyphilis, or Lyme disease. So with neurosyphilis, there's going to be, it's going to affect the brain, and there's going to be these gumas, and it can cause mood alteration, dementia, walking odd. Symptoms of meningitis are going to be neck pain, stiffness, photophobia, irritability, high fevers. And if we look at the CSF for bacterial infections, there's going to be high neutrophils, high protein, and low glucose. So if we think about bacteria, I sort of think that like they're in there and they're hungry. And so they want to have like lunch. So what are they going to do? They're going to eat lunch, and they're going to eat all of the glucose up. So that's why we have low glucose, because the bacteria are eating it. So with bacterial infections, we'll have low glucose. With viral infections, we're not going to have low glucose because viruses they're not like organisms. So they don't need sugar to survive. So the glucose won't be low. Neutrophils, remember, those are going to be high with bacterial infections anywhere else in the body. So that's why they're high here. Remember with Gilliam Beret, we said it was high protein. In some of the other ones, it was high protein, but no cells. That's how it's different from meningitis. Okay, I'll keep moving. So it is important to know your colors for this. And so know if it's gram positive or gram negative, know what colors it goes with, and know what these look like. So Neisseria meningitis is going to be gram negative, and H flu is gram negative, and they're pink. So they still ask it like on level 2 boards. They'll say that they have a diplococci, and they want you to know it's, we talk about meningitis, and they want you to know it's Neisseria. So make sure you know these like shapes and colors. They'll say it's a pink diplococci. So you have to know it's Neisseria meningitis. They won't just tell you it's Neisseria. So make sure that you know that. Or it'll like go through that it's an adolescent, they've got a rash, and they have like meningitis and blah blah blah, and they want you to know like what it looks like. So pink, cross eye. So we know it's gram negative. Staph aureus, group B strep, strep pneumo, listeria, is all going to be gram positive. So Staph aureus is cocci in clusters. Group B strep is going to be in chains. Strep pneumo is diplococci, and then listeria is going to be bacilla. So know that diplococci is in strep pneumo and Neisseria. They're both that, but they're different colors. Okay, just make sure you know this. Big star. Bacterial infections. So grossly, there's going to be engorged vessels, purulent exudate. So we see lots of like, it just looks gross, honestly. I mean, it's like pussy. There's going to be like, it just kind of looks green and like nasty and not what a brain should look like. Big vessels, like you shouldn't be seeing that. H flu is going to be like more basilar. Strep pneumo is going to be near the sagittal sinus. Microscopic, we're going to see tons and tons of neutrophils. That's what all these little dots are. And then we're going to see Virchow-Robin space, which is going to be the space around the vessel. So this red part is a vessel, and then we see like this space around it. So think on my microscopy that space is like keying you into bacterial infection. Okay, brain abscess. So patient has been shooting up meth and they get endocarditis, so infection of the heart. And let's say they also get an abscess of like their knee capsule because that happens. Then they get an abscess of like their spine. Well, then they also can get a brain abscess. So they can get abscesses and infections anywhere with drug use. So let's say they've got a heart infection, or let's say that they've got a congenital disease with a right to left shunt, or this chronic pulmonary infection. They can get a brain abscess. And it's got that central liquefied necrosis surrounded by fibrosis and swelling. The capsule is produced by fibroblast and surrounded by gliosis. And you can also see vasogenic edema here. Okay, viral meningitis. It may also be called aseptic meningitis because it's not septic, involving bacteria. Common causes are enteroviruses. And symptoms are going to be similar, but less sudden, less severe than bacterial meningitis. We're going to see normal protein, normal glucose in our CSF. And instead of neutrophils, we're going to see those cells that are going to be more for viruses, which are going to be our lymphocytes. So we've got, so an acute disseminated encephalomyelitis is going to be immune mediated instead. I don't think the post-encephalitis Parkinsonism is important. Okay, Arthropod-Borne diseases are going to be things like Eastern and Western equine or West Nile disease or St. Louis or Lacrosse. These are all epidemic encephalopathies. Again, lymphocytic, they're going to have multifoci necrosis of gray and white matter with neuronophagia. There's going to be nodules and then necrotizing vasculitis. So we can see that, and we can see that these are lymphocytes instead of neutrophils. And this whole thing represents a microglial nodule. Okay. Herpes simplex affects the temporal lobe. So anytime that you hear temporal lobe and like meningitis, encephalitis, think herpes. Children, young adults, usually neonates can all get this. So when we look at it, we can see these bodies. They look glassy, and they're called Cowdry type A bodies. Cowdry type A associated with herpes in the temporal lobe. Okay, in utero, we could get CMV. So this is a baby not even born yet. They'll have periventricular necrosis and calcification, and then microcephaly. Also, patients with AIDS can get CMV as well. So you get these owl's eye inclusions and localized periventricular subepidermal region. So here's our little owl's eyes. Okay, rabies are going to have our negri bodies. So all of these have, like, if you've noticed the pattern, all of these have their own little named things. So herpes has got Cowdry type A's, glassy looking bodies. Let's see, what's this? No. CMV has the owl's eyes, and rabies has negri bodies. So the negri bodies are these little bodies located that in the Purkinje cells of the cerebellum. So we're in these pyramidal neurons. So remember these neurons and the Purkinje cells, or they're located in the pyramidal neurons, but also here's the Purkinje cell, and that's what's shown right here. So with rabies, remember they've got this, of course, foaming at the mouth, and then they're scared of water, and they have like mania. HIV occurs 1 to 2 weeks of seroconversion in about 10% of HIV patients. So this is going to be the microglia are going to be affected and allow for infection with CD4 and chemokinin receptors, CCR5 or CXCR4. It can lead to primary CNS lymphoma. So what you'll see on path are going to be these microglial nodules again, and then these giant cells. So we can see big giant cells. Okay, JC Polymoveritis Pml is going to be a reactivation of the JC virus in immunosuppressed patients like HIV, chemo. Usually it's associated with HIV, but remember it can be other things. It infects the oligodendrocytes, resulting in demyelination. So in our demyelination lectures, we had talked about this. And so with this particular stain, dark blue stains for myelin. So we see these light patches. So there's no myelin in these areas. Subacute sclerosing panencephalitis is associated with measles. So sometimes people who are against vaccines might say, well, it's just a rash. Well, measles is not just a rash. You can also get subacute sclerosing panencephalitis. And it can cause cognitive decline, limb spasticity, and seizures. Again, there's myelin degeneration, gliosis, and there's inclusions in oligodendrocytes and neurons as well. Prion disease, we've talked about this before. Creutzfeldt-Jakob disease, CJD, is going to be abnormal prion proteins, PRPSC, beta pleated sheets. Genetic is going to be PRNP, encoding methionine or valine, and then neuronal vacuoles are going to be filled with protein aggregates. So we see these big vacuoles with Creutzfeldt-Jakob syndrome disease. Okay, a variant of this is going to be linked to eating beef. So it's not just the abnormal proteins version, it's the like viral version coming from eating beef with bovine spongiform encephalopathy. Mad cow disease, exactly, easier to say. So it is going to progress more slowly than the regular CJD. And what you're going to see on path is going to be these Kuru plaques that we can see right here. And aggregates. Fungal infection, Candida, are associated with diabetics, AIDS, patients taking antibiotics can get fungal infections because you're killing out all the good bacteria. So like the fungus among us is going to increase. So what we see is micro abscesses. Like if a fungal infection is just in one place, then that could be from antibiotics. If it's everywhere, this is where we get the problem. So with AIDS, like esophagitis, neutropenic patients can be a disseminated infection. You can get microabscesses or meningitis, and you can see the branching formation and budding. So we know that's different. It doesn't look like a bacterial infection because we've got that branching, which does not happen with bacteria. Cryptococcus is a capsular polysaccharide. So look at this big capsule that we see, those big halos on India ink. Chronic granulomatous infections may occur in immunocompetent people. So think about AIDS, steroids, immunosuppression. The gross morphology kind of looks like soap bubbles. So if you look up really close, it kind of does look like bubbles. I know that's like soap bubbles. They said that a lot in histology, but I think it kind of does look bubbly, or sort of like Swiss cheese, maybe. So it is visualized with India ink and then also mucicarmine stains. And it's also aggregating in the Virchow-Robin space. So that space right around the vessel itself. Aspergillus is going to be acute angle branching. So acute aspergillus. You can get fungus balls. So what happens is a patient has, let's say, tuberculosis, and they've got like some big cavity. The thing that sometimes affects the cavity later is going to be aspergillus. Or let's say that they had like a big abscess in their chest, sometimes like in their lung. Aspergillus will come in and like take over and create a fungus ball in that location. So it's gross. Invasive infections, it's going to be spreading to the brain, heart, lung. Allergies, allergic aspergillus and asthma. So just know if you see like think like fungus ball and think like acute ankles. So acute ankle. Mucor, so, or rispus is going to be a mucormycosis is occurs in diabetics. So it has that like terrible black looking face. It's hard to treat and it has right angle. So that's how we differentiate it from aspergillus. So right angle. Histoplasmosis is going to be endemic. It's important to know where it's located. So in the South, so Ohio, well, sort of South, Ohio, Missouri, and the Mississippi River valleys, Tennessee, has histo. And inhalation of spores or dust contaminated by birds or bat droppings, or how you get it. So somebody in a cave sniffing bat droppings. Pulmonary infections, it looks similar to TB, and then they get like this granuloma formation. And the gross morphology is like yeast-filled macrophages. So right here, we can see. So fun little fact. I have this friend, he is 80 years old, and he had like he like started feeling sick. He started having a cough. This happened last year. And he called me because he thought he was going to die. And he like, I sing, and he wanted me to sing at his funeral. So he like went and got COVID tested multiple times and he was negative. And then I guess somehow they got a CT. I don't know if they like did a chest x-ray. I don't know. Anyways, he got a CT and they found these nodules, multiple nodules, and it involves some lymph nodes. So he went to one cancer doctor and they said, well, I'm like, you have cancer. And I don't know why she said this. Like, never say this. Never say the word cancer until you prove it with a biopsy. But she said, you have cancer and you have 6 months to live, but never did a biopsy. So he was really worried and they were going to get a biopsy. And so they finally did. And it took like a month to get the results back. And I told him, I just wouldn't worry. Like, I just really don't think this is cancer. Like, he looks good. He hasn't lost weight, nothing. Anyways, it comes back and she said, I don't agree with the results. There's no way it's this. You definitely have cancer. You're not going to live much longer. Still, he feels fine. He has like a cough. That's it. And I'm like, I don't want to like tell you wrong, but I really think you have like something called histoplasmosis. And he's like, that's funny that you say that. That's what it said on my path report. Yeah. So she, so he went to Nashville instead and he had histoplasmosis and he had granulomas and he's totally fine now. So funny thing, like some of this stuff that we like learn, it can really like, you'll actually see it and maybe somebody will actually have something like this. So anyways, wasn't cancer, it was histo. Okay, blastomyces. You can get these ulcerated lesions. They've got the irregular raised borders, crusting, purulent discharge. How we remember this is blasto starts with a B and then broad-based budding. So here we are, broad-based budding. They've got these halos. It doesn't look like crypto halo. Instead, broad-based budding. See how it's like big old nuclei with budding. Look, here's our budding. Some more. So, blasto. Toxoplasmosis. Ingestion of undercooked meat like pork or lamb, and cat feces. So changing cat litter boxes. So it's a torch infection. So that is an infection that can cause problems to a baby in utero. So pregnant women should not change litter boxes. So this can cause retinochoroiditis, which is the most common, could cause stillbirth or cerebral calcification. So when we look at it, they've got these tachyzoids and encysted bradyzoids. So we can see all of this. So we see that central necrosis at the periphery. So make sure you know this picture. She'll probably ask about it and know that it's associated with toxoplasmosis. And here's what it looks like on gross morphology, this abscess near the gray white junction. Okay, but know this picture. Kind of looks like a, I don't know, beehive maybe, or honeycomb. Okay, Plasmodium Spalciprum is going to be a malaria, which is the main cause of malaria death in children. So we've got red blood cell inclusions. They're going to clump together and they form these like ring formations. So you can see like 2 dots and then a ring. So multi of these rings in the red blood cells. Tinea Solium. This is, I like almost bet this will be a question. It is ingestion of undercooked pork. It's a tapeworm causing cysticercosis. Anyways, it causes neuro cysticercosis, which is a neurological infection, and it is the leading cause of epilepsy in developing countries. It is not the leading cause of epilepsy in the United States. It is the leading cause of epilepsy in the world, in other countries that are developing, not us. Gross morphology, it can be caught in any place in the brain or any organ besides the brain. And then the cyst may be intraparenchymal. It can be attached to the arachnoid or just free floating. These cysts contain that scolex with the little hooklets. And so I would know this. And so if we look at what this looks like, it looks like this on pathology. So I would know these like cysts, like on gross morphology, we've got these cysts in the brain. So a patient, another country, develops epilepsy. Start thinking about undercooked pork, cysticercosis, and then know this picture as well. And it leads to further scarring and calcification. Ugh. Acanthamoeba are going to be free-living amoeba in the water and soil. So most people get exposed but not sick. Acanthamoeba keratitis is going to be a local eye infection with like soft contact lens wearers who use the same solution over and over again, or wear their contacts while swimming. And also can be in immunocompromised individuals and lead to granulomatosis, encephalitis. So here we are looking at this. We've got all of these cells right right in here. Okay, another parasite, the Glarula fowleri, is going to be a free living amoeba in waters, lakes, swimming pools, tap water, and not only immunocompromised, but immunocompetent. So anybody can get affected. It is the primary amoebic meningoencephalitis, and it goes to, you get the parasitic infection, death. So that is all of them. I left you with practice questions. Some are from like what she gives you, and some are at the end of the chapter from the book, Robbins. So, and they've got the answers and everything and explanations. So there you go. If you have any questions, let me know. I think the next session is Friday late. I can't remember the exact time, but I think that's when it is. But you'll see. You're welcome. Anytime.